I am here today to discuss behavioral health in our acute care services, and I'm doing this to help Christine because she was asking for brown bag ideas. And we'll have a few things that we'll talk about, but definitely leave time for questions and answers so that anything that might be unclear we can take care of for you guys. So we'll be discussing an overview of behavioral health, like what is behavioral health. Sharing just a few statistics. I actually have some handouts for you guys that have even more statistics, but I don't want to bore you with data. How patients get admitted to our hospital who have behavioral health issues. We'll discuss the legal system because when they do become a behavioral health patient under a Title 25 hold, they do enter our legal system. We'll also go quickly over our patient care team, our behavioral health technician role, our safety and security for our patients because they do require a different environment, and if my clicker will work, care plans and our length of stay. So we'll start with an overview of behavioral health. So behavioral health in our hospital really refers to patients who end up being placed under a Title 25, and I'll discuss that in more detail in a little bit, but mental illnesses are disorders of the brain. Scientists are doing more and more studies every day to see how a normal brain functions and what's going awry with neurotransmitters, neurons, all these different things in the brain that's causing it to not function correctly and cause these disorders for people. We see people with mental illnesses everywhere. You may not know that somebody has one because they can look just like you or I. They're very much stereotyped in movies and TV shows, but they can look like anyone that we may even know. So we usually see them in the hospital when they're in a crisis, and that's when we have to come up with plans to keep them safe. So some of the diagnoses we see are depression, anxiety, bipolar, schizophrenia. We see people who try to attempt suicide. We don't have great access to mental health in our community and in our state. This creates barriers, and this is why we see them on the acute care side, because this is usually their first access to getting help. Do you guys have any questions so far? I have to look at my notes. I put a lot in here. Apologize. So I'm going to share some statistics with you. All right. So in 2014, 15.7 million adults reported having a major depressive episode in the last year. So only 33% of them actually sought help. And they only seek help because they're at the point where they've hit their crisis. Others will not do it because of stigma, because it's not okay to be crazy. It's not okay to be sad and depressed. It's not okay to have normal feelings. So in Wyoming, we're kind of known as the pull your bootstraps up and deal with it state, so they really don't seek a lot of help. So the 33% was national statistics, and I'll let you know in Wyoming, only 41% obtained help. So we're still, a little bit better in some respects, but when they looked at the lifespan, it's not really good. Serious mental illness costs America $193 billion a year in lost income. People with mental illnesses can actually die 25 years earlier than anybody else within their age group because they have other conditions that aren't treated because of their mental illnesses. Suicide is the 10th leading cause of death in the United States. And I believe Sweetwater County is number one, last I heard. Okay. So, when everybody is talking out there like, gosh, we have a lot of these patients now, we do.
Yes.
We do. We are seeing it, we're feeling it. So I found this interesting information from NAMI, which is the National Alliance for Mental Illness. And this shows the states in the last fiscal year who either increased their spending for mental health, decreased it, or left things the same. And Wyoming, unfortunately, is one of the 12 states who decreased their spending. And there's still talk at the state legislature of cutting even more funding for behavioral health. So I'm going to put a little plug in that we need to get to our legislatures, and we need to share with them our concerns about not dealing with mental illness in Wyoming.
Do you have any idea why they're doing that? Because I know Brenda.
It's money.
Yeah.
It's money. It's expensive. It's costly. When we don't have the appropriate settings and the appropriate therapies for patients, the acute care setting is very expensive to treat our patients with mental illnesses. And we're not providing support. So then, and I'll talk about the length of stay in a little bit, but the length of stay, that cost increased significantly.
And
so they've expended their money already because of the volumes that we've had.
And reimbursement and insurances is way lower for mental health than it is for other different types of disorders too. So it's not.
So I thought this was pretty telling. I thought it was an interesting representation. Very disappointed, but we do have a voice, and it takes all of our voices, collective voices, talking to our legislatures to make change happen. So how do you get admitted to the hospital as a behavioral health patient? I did steal these pictures from Phil, from a previous presentation he had. We share, it's awesome. So typically patients present through Phil's department in the emergency department. They'll come in by family, themselves, by police officers, by the school district, because they are expressing harm to self or harm to others. So they come in for an evaluation, and some patients were able to come up with an outpatient plan, figure out the safest place for them, and we discharge them. Others end up being placed under a Title 25 hold. So that is when we enter our legal system. So our Title 25 is actually a Wyoming state statute. It's a statute that says you can hold somebody against their will in a hospital for 3 reasons. They're at a harm for themselves, they're at a harm to others, or they have a mental illness that they can't take care of themselves and they're not taking their prescribed medications. So we have to be careful when we're putting somebody under a Title 25 hold, because we actually take away their civil rights. So all of us today sitting here have civil rights. Our patients still have civil rights, and when we title them, we actually take a lot of those away. They're not free to leave the hospital. The county court system actually ends up becoming their decision maker until they're finished with the process. So the rights they have are very limited. They have a right to contact their family. They have a right to contact an attorney. If they can't afford an attorney, they will have one provided to them. And they have a right to remain silent, because anything they say can be used against them for involuntary hospitalization. Those are their rights. So that's a big deal, to take away somebody's civil rights. So we want to make sure that we're not breaking the law by titling somebody. So I'm going to read this, and it's very long, but I want you to see how complex this can be when we talk about patients who cannot take care of themselves. So it's evidences behavior manifested by recent acts or omissions that due to mental illness, he is unable to satisfy basic needs for nourishment, essential medical care, shelter, safety, so the substantial probability exists that death, serious physical injury, serious physical debilitation, serious mental debilitation, and destabilization from a lack of or refusal to take prescribed psychotropic medications for a diagnosed condition or serious physical disease will imminently ensue, unless the individual receives prompt and adequate treatment for this mental illness. No person, however, shall be deemed to be unable to satisfy his need for nourishment, essential medical care, shelter, or safety if he is able to satisfy those needs with supervision and assistance of others who are willing and available to help. So, when we talk about titling patients, if they're a harm to themselves or a harm to others, that's pretty straightforward. Where we get into the gray area and we really have to pay attention to is when we say, well, they can't take care of themselves. Okay, well, they may not be able to take care of themselves, but do they have a mental illness? Do they have medications that they're supposed to be taking and they're not? Do they have somebody who's willing to take them home and take care of them? Because that is the least restrictive environment. That's where we want our patients to be. But it's very complex. So the rest of the process is, once a patient is placed under a title, we have 24 hours to evaluate them with a mental health provider, which is right now serviced by Southwest Counseling. So within that 24 hours, they get a mental health examination, we make a plan, and within 72 hours, the county court has to hear their case if we don't come up with a plan prior to the 72 hours. So we're headed into Christmas, and 72 hours does not count for any state-recognized holiday and weekends. So we have patients, if they get titled on Wednesday before Christmas Eve and the county court decides to take Christmas Eve off and Christmas Day off, those 72 hours won't count. The weekend won't count, so their time will actually start on the following Monday. So it's a very big deal, and our patients get confused. So the 72 hours is working business hours. Kind of scary, huh? So imagine being a patient here for that long, under a state statute saying we can't actually do this to you and keep you here this long. So they'll go to a hearing within 72 hours, and it's with their attorney that's appointed to them most often, and the judge. The judge who hears the cases right now is Judge James, and they present the case. This is what their plan is or their lack of plan, and at that point in time, the patient can decide, I'm going to waive and I want a final decision right now. So that the judge can make a final decision at that first hearing if the patient says, I'm waiving my right to my final hearing. That's not always what happens because it's their first hearing. If they say, no, I'm not ready, I don't want you to make a decision, the patient's actually court ordered to remain in our hospital detained for another 5 to 10 working business days. So, again, I'm just going to use the holiday as an example. So if we have somebody who went to preliminary hearing and didn't waive to final, and they're court ordered for another 5 to 10 days detained here for their final hearing, so today is Wednesday, they will not count Saturday and Sunday in, they won't count Christmas Day in, and if we don't get the hearings done before Christmas or New Year's Day, they will be here past that other weekend before they have a final hearing. So our length of stay can increase significantly just based on the court process that we're mandated to. Does that kind of make sense? Or is it clear as mud? Because some days it gets as clear as mud. All right, so we'll go on to our patient care team. So it takes several people to help out. Physicians, nurses, administration, nursing leadership, case management, our behavioral health technicians, and Southwest Counseling. Who's not on here is security, and they are part of a team, so I apologize, Bill. The roles have changed a little bit, but each one of these people have a role. Our physicians are making medical diagnosis. They're ruling out to make sure their thyroid isn't making them have these symptoms of depression or these symptoms of psychosis. They're making sure that their lab values are normal, so we need our physician partners to rule out medical causes. Our nurses are taking care of the patients. They're boots on the ground, interacting with them. They have a lot of requirements. They have to document on our patients every hour. So it's kind of a big deal. Our administration helps keep us focused on task, making sure that we're not missing anything as far as guardianship, safe plans for the patients, and staying within our laws. Our nursing leadership team shows up. Case management helps with disposition. They actually attend the hearings. Our behavioral health technicians are the ones that do the every 15-minute documentation on the patients, watching for a safe environment, making sure patients and staff and visitors are safe. And Southwest Counseling has a limited role, and they do not provide counseling services in the facility. They provide the medical examiner services. So they're the ones that do the medical examination, and they follow up every day while the patient's under a title. We're not a psychiatric facility. We're not licensed as a behavioral health facility. So we really can't look and act and walk like a duck and just say, oh, but we're not. We have to make sure that we're being careful. So we are limited in the services we can provide. So this whole group meets Monday through Friday at 9:30 in the morning in the emergency room. And we discuss our cases. And we discuss what we need to do to keep our patients safe, get them in the right environment, make sure we're maintaining their rights, getting them the correct privileges, and proceeding through whatever process we need to get them discharged or get them through their court hearing. So our behavioral health technician role is new. We hired behavioral health technicians, our first team, in June of 2014. So we've been doing it for about a year and a half now. These individuals have made a huge difference for our patients. So prior to bringing our technicians on site and training them and saying, this is what we want to see from you, we had a contracted service. And the contracted service would literally sit at the desk and stare at the patient. So can you imagine having somebody stare at you and not talk to you and not acknowledge you and not do anything for you for 12 hours a day and then 12 hours a night? And they would stare at you and they would write things down, and everything you're doing they're writing down, but they're not interacting, they're not talking to you. We wanted to change that. We wanted to make the care as best as we could, considering we're not a psych facility, as we can for the patients, especially because they're staying here longer. So We have 2 teams now. We actually are cross-training hospital staff. I actually have a couple of my cross-trained staff members here, and they're awesome. So the difference we've seen has been phenomenal. We're actually getting thank you cards from our behavioral health patients, which has like never happened ever. They're appreciative of the fact that they're being talked to, they're interacted with. We help them go on walks, we help them play games and color and draw and other things. They provide a light for the patients. Sometimes it's a listening ear. They just want somebody to talk to. And our technicians are able to provide that role where we weren't able to do that with our contracted service. So our contracted service has not been on site since September 1st of this year. So we have all of our technicians and our cross-trained technicians, and it's been absolutely fabulous. So you may wonder, well, all I do is see them sitting there. Right, well, and that can happen. If they have more than one patient, they really can't be in the room interacting with another patient because then they're not keeping an eye on the environment. Julie can probably vouch for this, Leanne. It's really hard to sit there for 12 hours without things to do. So you may see them reading and you may see them watching a video, but they are primarily watching the safety and security of the patients. They're documenting in our records, in our electronic record. So we have good trends and we can see what behaviors are doing like this and not on paper anymore. So it's been fantastic and they've learned those skills as well. So any questions on the role? Because it's new. All right. So we're moving along to safety and security. So these pictures are a little bit small, but these are pictures of one of the detention rooms down in the emergency department, and I also borrowed these from Phil from another presentation. So you can see it's pretty minimal, right? Could you imagine being stuck in that room for hours on end and somebody staring at you through the window? It's kind of not good. So, but we do have to provide a safe environment. So you can see on here there's very minimal places for them to tie a sheet to or anything else to try and hang themselves with. We want to minimize where they can hang themselves. We did have one incident where a patient did try on the bathroom door and now the bathroom doors have changed. So that can't happen. So, and the technician at the time saw it, did everything appropriately to make sure that the patient stayed safe. So when we have our team meetings Monday through Friday, we say, is this the safest room? Or are they a low enough risk that we can put them up on medical floor in a less safe room? That's some of the discussions we have. So let's see, there are multiple regulations when we put patients in these seclusion rooms that we have to make sure that we're maintaining. So that's the documentation I spoke about earlier. And security has been fantastic because they do provide a safety role for us. We do on occasion get patients who are very violent. They try to hurt themselves, but they're violent towards staff and others. And security helps us. So our highest risk patients, they'll provide standby. The staff doesn't even interact with that patient without security being there. So we're very appreciative of our team members in that role. And then some of the little things that you wouldn't think about, but we have to be careful with what we give them when they eat. So they don't get knives and forks. They get 2 plastic spoons to eat with. So you can imagine it's really hard to eat spaghetti with 2 plastic spoons. So some of them are so high risk that they only get finger foods. They can't even order foods that require utensils. They don't have pop cans, so we have to send them sodas without any metal. They have to get it poured by a dietary. This can present a problem when we have paranoid patients who think we're poisoning their food. So we've recently met with dietary, and we've come up with a plan that if the patient's paranoid about their food being poisoned, that we'll open all that stuff in front of the patient. They'll send it up, even though that's not against their rules at this point, they'll send it up for the staff to open in front of the patient to try and help and get them to eat. So it's little things like that. How many linens are we giving them? Or what are they doing if they pull the blanket up over their head? Like, what are they really doing under there? What are they really doing in the bathroom? We just have to be careful. We've had patients, families, hand things off to them, and that's not good, so that presents a safety risk. So you can see that it's a difficult situation. It can be quite challenging to manage, but I feel like we have a solid team in place to help look at risks and try and minimize those risks. All right. So we're going to talk about care plans and length of stay, which I've kind of already talked about with our meetings Monday through Friday. We look at privileges. Can they have a phone? Can they have visitors? Could you guys imagine being in a place where a team of people is deciding whether or not you can talk to your loved ones, whether or not you can have a visitor, and how long that visitor can stay, and if you can have something to read, and if you can wear your own clothes? It's a big deal. So we take looking at patient privileges very seriously. Our patients have become more complex. We used to see pretty much as awful as it may sound, a straightforward suicidal ideation. I'm sad, I want to hurt myself, I don't want to be here anymore. We can help them with antidepressants and get them on the path to recovery. We're seeing schizophrenia, not taking medications. Our hospital does not force medications and we don't force fluids, so because we're not a psych facility. So it makes it very difficult for a paranoid schizophrenic who's in an acute stage and a crisis to get them managed because they won't take their medications and we can't force their medications. So we do have challenges when we take care of our patients. Length of stay can be from hours to weeks. Patients who have insurance, who are adolescents or children, can usually get out of here a little faster because parents can involuntarily place them into a facility because a child can't sign themselves out. But if we have somebody who tried to kill themselves and they want voluntary placement, but they've tried to kill themselves, they can check themselves out because they're an adult. So if I say I'm going to go voluntary, sorry I took 50 of those pills, but I just want to go voluntary and take care of this, they can get down there, never go, and then check themselves out. So adolescents are a little bit different. We do send to a couple places within the state. The Wyoming State Hospital itself is very limited for beds. So we send patients to Pine Ridge, which is in Lander, or WVI, which is in Casper. Our adolescents and children can only go to WVI. So WVI is full, we don't have beds, we sit on our patients for quite a while. So our length of stay literally can be hours to almost a month. And that's a long time for our patients to be here. And it's unfortunate. So a little bit of food for thought, because it sounds a little scary, and I'm not trying to make it sound scary, because it's not. We recently had Dr. Bongiorno speak to our behavioral health technicians regarding, interactions with patients. Some of them can be quite manipulative, and they'll say, well, Christine was really nice to me last night, and she did this and this and this, and so why aren't you doing that? And then Joanne's like, I don't believe it. and so then they'll get along, and then Christine will come back and they'll be like, well, Joanne let me do this and let me do that. Mm-hmm. And they can split the staff. Mm-hmm. And so that's not good for a cohesive team and a plan of care. So that's just one example. They can be manipulative with food and visitations and phone calls and just anything that they can have control over, because they don't have a lot of control during this process. So Dr. Bongiorno wanted to share, and this is what he shared in the past, is to be kind, polite, and build rapport with the patients. There is a stigma associated with mental illness and behavioral health, and patients already feel embarrassed and disgraceful. So give the appearance of extra time, be present in your interactions, and first impressions are always important. I can't tell you how many patients will tell us, I didn't like the way they walked in the room. Just a simple, that first impression, how I'm walking in, maintaining eye contact, the tone of my voice and how I say things is going to make that lasting impression. Listen to them and be respectful. They're people. They're somebody's son or daughter. They could be somebody's mother or father. You don't know, but you would want them to be treated kindly and compassionately like your family. Involuntary commitment causes feelings of discomfort, anger, and frustration for patients, and rapport sometimes has to be developed slowly. And it's not always possible, but we have to be kind and compassionate. Safety is paramount and most important. Our patients can become quite opinionated, and it's okay. They have more hours in a day sitting in a room to think things up than we have to figure out what they're thinking of. We have to deliver a consistent message, which is why our team meetings are so very important. We have to learn how to say no kindly, because we do have to say no. And our behavioral patients should always be treated the same as any other patient. They are just as important as somebody coming in with a trauma, surgicals, having a baby. any reason that they're here, they are just as important as the rest of our patient population. And remember, they die 25 years earlier than normal patients, so we have to make sure that we're treating them kindly and compassionately and not ignoring their medical issues. So with that, what questions do you guys have?
Do we know how many patients are like veterans with post-traumatic stress syndrome?
It varies.
Okay.
We do see a handful of them. In that case, we try to work with the VA in Sheridan
Uh-huh.
and get them there. The VA in Sheridan won't take them unless the county court has court-ordered them to involuntary hospitalization.
Wow.
So, so we do get them, and we do try to get them to the best setting, but they oftentimes won't take them as an acute transfer unless they've been court-ordered by the county court.
Or even treatment through the VA here at the facility?
Right, if they come to us in an acute crisis, then they end up in the Title 25 process.
I see.
And so then that's why the rest of that plays out as it does.
Uh-huh.
So we do see a handful. I don't think they're the majority though, do you think, Phil? I don't think they're
Okay.
majority. The majority of them are really suicidal ideation.
Uh-huh.
So, any other questions? We have plenty of time for questions. Was this information helpful to kind of understand where we're headed? And you can see the state is planning on decreasing funding and has decreased funding. So they're not acknowledging the issue at the level I personally would like them to see it acknowledge at. But I'm very proud of our organization for taking a step out there and saying, at this point in time, we will take you. We will take care of you to the best of our ability. We will keep you safe and get you onto the next level of care when we can. You know, we're kind of at the mercy of the courts and then the bed availability through the state. But I am proud of our organization. I am proud to see that we've gotten a team together to make sure that we're maintaining patient rights and taking care of them to the best of our ability with our limited resources. So there's only 4 hospitals in the entire state that are actually dealing with this.
Yeah, that was going to be my next thing, is why is it just because of our location that people, I mean, we have such a huge population of behavioral
We do.
patients here. It's just
We do, and if you look at it, it's, so we're only one of 4 hospitals dealing with it. Other hospitals will treat and straighten them. They'll give them a bus ticket out of town,
Right.
you know, so where are they gonna go, right? The 4 places that actually will do something. Being on the interstate, we get a lot of transient patients, people who are traveling through, who may not have remembered to take their medications. They get in car accidents.
Right.
We end up with them with car accidents. We call it the I-80 vortex. They just get sucked in here.
What do you
And-
think would encourage more providers to come here? I mean, seriously, it's such a serious situation.
It is serious. They are actively recruiting. We've had several psychiatrists do on-site visits. Part of it is us showing a passion for our behavioral health patients and wanting to do the best and being like, oh, you would be so great on our team, and these are the things that we could get accomplished. And when they're doing their on-site visits, we're part of that recruitment. I don't know if you guys realize that, but we are part of recruiting physicians to the area. Sometimes the spouses don't like it here. It's not metropolitan. There's not a lot of things to do. So that kind of drives people away a little bit
Plus,
too.
we really don't have a facility.
We don't have a facility, and some providers are very nervous about working in a smaller community, and especially in mental health, because then it's like, well, I don't want to get in a therapy session in the grocery store, because I may see them out in the community. You know, so it's a little bit harder to pull providers to a rural area where they may see their patients
Yeah.
in an outside setting versus metropolitan where it's like, yeah, sure, I live in this way over here. Right. Right.
Oh.
Yeah.
I would just, I don't know why I'm sitting here thinking about it, and I guess it's because it's Christmas time, but if we ever consider doing a intra-hospital fundraising thing for providing activities for things like that, you know, we put a hat and mint tree, we put toys for tots, we put, you know, all those things, maybe we
Sure.
should consider, you know, just coming up with some extra things for activities, whether
I
it be
think that's,
puzzle or card
sure,
games
I think that's
or-
a great idea. I do provide within the budget right now, card games and drawing, colored pencils, crayons, and markers. Sometimes they can't have the colored pencils because if they're a cutter, they can make it sharp and cut themselves and hurt themselves while they're here, and we don't want that to happen. So markers and crayons are the best, and we've bought composition books, the ones without the spirals on them, so that they can journal if they want to journal. It has to be safe activities, but I think that's a great idea. But we do make sure, I make sure to pick up supplies for them to have some things to do as well. Not sure about the puzzles, because we get into the, well, they swallow the pieces, is it okay? Because they swallow random things. You know, we've had patients who have swallowed spoons, like, I mean, so you have to be careful the activities that you pick for patients, so, but that's a great idea. Any more questions?
Your explanation on titling was great, because that's very confusing to
It is
me,
confusing.
too, to a lot of people you deal with.
Sure. After having done this with our behavioral health team for the last, couple years, I've got it now. Good, like, I get it, but it is confusing, and it's
really
gray, and it's muddy. And I'm very proud of our staff, because they're finally coming into their own as far as, well, that doesn't sound like we can title that patient. And they've actually called me on a couple cases, and I'm like, you really can't, like, the law is very clear. We can't title patients who have substance or alcohol abuse. So if they are an alcoholic, they have a right to be an alcoholic in the state of Wyoming. And we can't title them and send them to treatment.
And as a nurse, it's really hard, it's really ethically hard to take care of patients when their rights have been removed, because you want everyone to have a right.
Right.
And it's plays games with your mind when you do that,
And-
because
and
you
maintaining
want to give them rights.
Yep, and maintaining
Like
safe
everyone else.
boundaries too. Like, you don't share a lot of information about yourself. Because we've had a couple instances where the patients had progressed to internet access on a personal electronic device, and they were finding staff members on Facebook and writing love poems, and I mean, so and the person didn't disclose anything, but was smart enough to figure out how to find the individual on Facebook. So you have to be careful in setting boundaries, and it's hard because most nurses develop relationships with their patients, and it's that give and take, and you give a little information and you get a little information, but behavioral health's a little bit different.
So when they're titled, do they then become like a ward of the state and then
Right, so they start out as a ward of the county
of the county?
until
Okay.
they go to final hearing.
Okay.
And if they're court ordered to the state, then they become a ward of the state.
And then they can be placed in a facility?
Wherever the state says to send them.
I see.
Yeah.
Okay.
And I'll get to you in just a second. What's really important to know about that is then the patient can't consent to, can I have the surgical procedure?
Right.
Like, we actually have to ask the court system for permission to do a surgical procedure, because the patient can't consent.
And as I understand it, if they're court ordered to be wards of the state, they cannot be placed out of state. then.
Correct, that is correct also. So
that
the title
limits
does not
it.
cross state
Yeah.
lines,
Interesting.
which is why we don't transfer patients to Colorado or Utah. If the state has said, yeah, I've court ordered them to the state of Wyoming, they're in the custody of the state of Wyoming, and we can't cross state lines. Great, thanks for bringing that up.
So, well, I was frustrated by that.
Yeah.
I'm confused. Why aren't these kids going?
Yeah,
when they can't?
and they can't, so, yeah. It's complex.
Sydney, I'm trying to remember about charges. If someone comes from like Gillette and comes down here to the safe house and something happens and they end up being titled, is there county of origin charge or?
We attempt to charge the county of origin, and if we don't know the county, because we do get people traveling, we bill their state.
Oh.
So, but I can tell you reimbursement and getting money back is very difficult for behavioral health. It's just not
It's
well
just not there,
funded.
yeah.
So, facilities are closing nationwide. So, it's unfortunate that we're not acknowledging the problems that we have.
And the problem of behavioral health, or the diagnosis of behavioral health, is increasing
It is.
nationally, so we're not the only
Yeah.
facility
Yeah, people are seeing
experiencing
more and more.
challenges.
So Cheyenne, just a couple months ago, their ER had like 11 patients, 11 or 12 patients in their ER, and they weren't even able to see normal, emergency room patients because it was full of behavioral health, and their behavioral health unit was full. So we're not the only ones struggling with this. We've had other counties call our hospital wanting to send us their behavioral health patients, and we have high enough volume that we can't accommodate another county,
We're
so.
gonna pay for it, not, I don't mean us, but I mean the United States.
Yeah.
We
Well,
are
yeah.
paying for this, big time.
I'm wondering if are there, when you talk about statistics, then you see the statistics of these people going out and doing crazy things like shooting people who are nuts. So that now you're talking about the money for incarceration.
Right, right.
And how much that is.
Right, and I'll give you guys these handouts, but there about 20% of people who are incarcerated actually have a primary mental health illness.
Wow.
So,
Yeah.
Just another place they can shuffle.
yep,
That's it.
yep. They can't get the help they need. They self-medicate. They have to steal things to keep up, whatever they've got going on,
Right,
because they're not in the system in the healthy way.
right.
Yeah.
Could be homeless,
Right.
that kind of thing.
Yep. So mental illness oftentimes starts manifesting itself around age 14. And then the rest of it starts around age 24. I mean, you can see it at any point in time, but those are kind of your two key areas. So.
And are there any programs, when you say suicide is the number one thing, are there state programs with just that in mind?
So there is a suicide coalition. So we actually have a county chapter working on it. So I would watch you can become a member if you want to. Callie Mickelson would be the person to get in touch with. She has all the information on that coalition. But they're working on an ad campaign for suicide prevention for the county. And some of it shows big, strong, strapping Wyoming men and saying, it's okay for you to be sad, but you need to get help, kind of thing. So they're trying to make the awareness much more prevalent. So I was trying to remember if there was anything else on the statistics I thought was interesting. I didn't want to bore you guys with data, so.
It makes an impression though, it kind of makes it real when you hear the numbers too.
More than 90% of children who die by suicide have a mental health condition. So almost all the kids who die by suicide have a mental health condition.
Wow.
And each day an estimated 18 to 22 veterans die by suicide. So it's a significant problem. So on that happy note.
Yeah.
Are there any other questions? Well, I appreciate your guys' questions and your discussion. It's very helpful. And if you have questions on our process or what we're doing, feel free to ask Phil or I. Callie Mickelson, the case manager, Deb Gaspar, all of us can help out with those things. So.
Very cool.
All right.
Thank you.
Thank you.